Welcome to the Frank and Lizzie Show. My name is Frank Lizzie. I'm one of your co-hosts, and with me, I want to also introduce my virtual better half, otherwise known as Lizzie.
Hi, I'm Liz Faust. I'm a nurse practitioner in Reading, Pennsylvania. I am happy to join Frank today for this episode. Frank, what will we discuss today?
Well, I'm glad that we're talking about this because I have somebody who I admire. He's a vascular physician and also wound care physician. He's done a lot of work on a lot of different areas, but today he's going to introduce us to cutting edge technology.
Oh.
Do you want to know who it is?
I do. Do tell.
Dr. Mark Melin. So Mark, thank you for being here.
Hey, it's my pleasure. I'm excited to be with you two. You two have a phenomenal show, a great following, and it's because you guys do such a great job of educating.
Oh, thanks.
So I'm excited to hear about this new technology, Phoenix Wound Matrix.
I love new technologies because one of the things that we should all be looking for is value. So what can we utilize in technology that advances the science, takes the best available from benchtop research, is moving it to the bedside, but really starts to introduce components of wound care that are largely not thought of. And one of the great things about Phoenix, where they've really hit a sweet spot in opportunities, is wound pH. And paying special attention to wound pH, because most of the chronic wounds that we have dealt with over the course of time actually have an elevated pH.
Wait,
so
what is this product called?
It's called Phoenix. The company is Novoderm. Phoenix is it's kind of like the fire of rising, right? Think of Harry Potter, the Phoenix.
Yeah, I love it.
As we look at pH, most of the wounds, and I've missed this my entire career, chronic wound pH is usually like 7.15 to 9. Your skin, your intact skin, 5.5. So where the bacteria that wants to keep your skin healthy is at a 5.5. And here we've been missing this element for so long. So here's a product that has really unique characteristics of being electrospun, two types of fibers that we've used in the operating room, polyglycolic acid, and then another component, much longer name that I'm not smart enough to say, ultimately breaks down into lactate. Now, you'll think lactate is bad, right? But actually it's interesting because I was going through some data, because Frank knows I love data. And this particular mouse model, lactate stimulates angiogenesis and accelerates the healing of superficial ischemic wounds in mice. It was really eye-opening to read about the component of lactate improving angiogenesis through its impact on like VEGF, right? Vascular endothelial growth factor. And it kind of makes sense because wounds tend to be hypoxic. So you'd expect there to be a little bit more lactate. So teleologically, you would expect the body's function would be that lactate is trying to drive out of that chronic inflammation into that proliferative phase to get to the remodeling, etc. So, but most of the wounds we deal with are stuck in that chronic inflammation. So this is a durable, in fact, I've got a piece sitting here right here. It's durable. It's conformable to the wounds. It fits into all the nooks and crannies. You can cut it up. Very easy to cut. There's no upside down. This particular one is fenestrated for a heavily reducing one. And then the unique thing about this is it'll stay in the wound bed 7 to 14 days. So it doesn't break down immediately. So one of the environments you could put this in and say is under a 2-layer wrap that you may only change once a week. And now you've got stability of a product that offers continuous degradation, but that degradation is actually then improving wound bed prep to get us to the next point.
Hey, Mark, I've worked with some products before that are like, advanced wound care or like cellular products, and they're kind of challenging to work with because they're either very thin and delicate or they're kind of like slippery and it's hard to get it to like adhere to the wound bed. But you just mentioned that it's like very durable. So, can you describe to perhaps our audience or to me, like what makes this unique versus some of the other products that we may use for advanced wound care?
So I'm going to hold this up again. So long shelf life, 2 years, right? Can sit on your shelf. You're going to have the rate of use, you're not going to be throwing away product. But if you go to pull at the tensile strength, right, the architecture at that nanofiber, because of the electrospun component in the 3D type stuff, gives it great tensile strength. So it doesn't fall apart in your hands. I can stretch it, I can pull it, I can cut it, I can tuck it underneath undermining. So that's one of the really unique characteristics about this, is that tensile conformable strength. And that gets back down to that electrospun nanostructure. Because if you really look at this underneath a microscope, there's the nanofibers. If you match it against the size of a red blood cell, so red blood cell is 5 microns in size, fibroblasts are 10 to 15 microns in size. If you make the nanostructure too big, the cellular components literally cannot grip and then migrate along to do what they're supposed to do in terms of proliferation. So I've heard an analogy saying it's the right size rope for the cellular elements to grab onto. And you can imagine when we're rope climbing, if something's way too big, it's hard to get a grip on. This provides those cellular elements wonderful grip in creating that low pH environment to do the angiogenesis, to change the inflammatory components. And then really, if you change the inflammatory components, that's where you start to tip into proliferation.
Well, Mark, this is great because it's making the clinician a scientist, it sounds like, because you can actually change the wound environment. So do you have any cases that you can show us to that?
There's a lot of people that are utilizing this. This is one of my personal cases. This is showing molecular imaging, because one of the things that we have to recognize simply is the wound bed. And many of the tissue products, many of the products we use, if the wound bed prep isn't perfect, it's going to kind of degrade that element much quicker, and we may not get full utility out of that particular product. So again, because, and if we look in this border, so here we're doing the measurements, we're looking in the molecular signal showing those perviridins and porphyrins, some of the cyanins, so we know those bacteria. So accurate wound bed prep, debridement, 10 blade, washed with a hypochlorous acid, we're trying to bring down the pH. And so we're trying to get this ready. Now, I would feel comfortable putting something like this in this wound bed, even though I may not have perfect resolution of the porphyridins and the porphyrins, the bacteria leaving that molecular signal. So if I had other products that maybe aren't as durable and aren't made for this environment, this is made for these really challenging environments that we deal with in our clinic, that you both deal with all the time. So it gives us a little bit more latitude in applicability that also increases our confidence in what we're going to end up seeing. So in this first one, necrotizing fasciitis, right? Surgical debridement, standard of care. And then how do you deal with that wound bed prep? Well, these wounds can be incredibly complex. So this one, the thing to pay attention to is this is 11 days, right? 11 days from a wound that has minimal granulation tissue. Now, this is an acute surgical wound, right, that had a really nasty infection associated with it, appropriate surgical debridement of necrotizing fasciitis, and then starting to apply this electroscaffolding that's 3D, that lowers the wound pH to maximize angiogenesis. And look at what's accomplished in 11 days. Now, a lot of people would say, well, you had a negative pressure wound therapy on there. This was just with this product, the Phoenix. So there's great utility in that case. Frank, tell us about the second case.
Yeah, and something, Liz, I got to disclose is that I was approached when this company came out, and I've been kind of looking at this product, and it got my attention. I'm not employed by them. I like gadgets. So this is a case, a patient that was not healing, diabetic, foot ulcer, complicated with pressure injuries, and also osteomyelitis. And I just want you to know, this is my first case ever, and he healed in no time, but the tissue changed in 7 days. It was robust. So after the fact, it's when we started learning that it changed the environment completely.
Yeah, it's interesting. There's no good clinical way to describe that visual change in the granulation tissue, right? So like when we're documenting, it's not like you can say, it's like not healthy granulation tissue. And there's a certain eye that you learn after time. So like, you know, in each of these cases, you can look on the left side of this case study and say, that's not a healthy wound if you have that clinical experience. And then you look on the right side of the wound and you say, oh, that's going to heal, right? Yeah. And I think we've all visually seen that, but to be able to describe that has been really challenging. And I think, you know, the more we get this literature and the research and the technology that can feed that, because, you know, I've recently come upon this thing of do no harm also means not neglecting your patient needs. And when your patient is in a pro-inflammatory state, to not neglect that inflammation and to address it, right? Because do no harm is typically like you're not going to physically harm a patient, but it's also not neglecting their needs, right?
Right. That's a great point. You know, and to put it in context, because looking at these static images, we're dealing with a dynamic situation when we're in the clinics, right? So we're looking at, tell me about fevers, chills, sweats, pain. It's another component we've seen change with time as inflammation goes down. So the pain component starts to decrease. We see maybe less odor, less drainage. We see less hyperpermeability because there's less interstitial edema formation because there's less inflammation. And I always, whenever I see people like this, I want to look at Frank and give him a big hug, because as a lymphedema specialist, right, you got to treat the lymphatic dysfunction in these feet to maximize outcomes. In fact, the acronym that I shared earlier was PLAN. What's the plan? P is pH, L is lymphatics, A is ABI, angiogenesis. What's the arterial flow? And then N is nutrients, right? So don't ignore the micronutrients like B12, B6, folate, D3, vitamin C, all these things that help immune function and reduce that teeter-totter of oxidative stress. We're trying to lower oxidative stress, lower the reactive oxygen species. So what is the plan? But it starts, pH is something that is such a low-hanging fruit for an opportunity to educate our colleagues on.
Mm-hmm. And Mark, you know, you've seen this product before, and I'm going to let you talk about the case on the right side too, is that most of our patients were patients that had no other choice, complicated, nothing else. And it was amazing to actually see the results on people that were going to be amputated. And again, I'm not saying that product is going to save limbs for everybody, but picking the right product for the right patient is utmost important.
Well, I think the other beautiful thing about this particular product is the broadness of applicability, right? It's a value-based that we know kind of hits on all these type things as a cutting edge type of bioscaffolding. And again, it's a beautiful design. A lot of work went into this. Benchtop research is what led to this getting to the clinical bedside where we now have the opportunity to use this. So I think it hits on all those aspects. And you know, leadership has done a phenomenal job. Again, when you look at the development component and the testing that's been done even in the veterinarian world, right? So I've heard some incredible stories about, at least when you look at where horses, cows, etc. live, that's a tough environment. And when you get clinical outcomes in an environment like that, you know, that's really a great proving ground for us in our clinics and patients' homes.
This case on the right, I've seen these wounds before. They don't heal. Like, they really are just super challenging to heal. And this one's a 2-year ulcer. So to see that improvement in that wound is phenomenal. I think I'm really impressed with that case study. But across here, I'm seeing there's a variety of sizes. And I know you showed me a piece of that Phoenix that you described. I want to know, what are the sizes? Like, how logistically, how am I going to stock this item to treat all of my patient population?
So what I want to look at the lower right-hand corner. I am so economically focused that I don't like to waste product, right? So I don't want to do something and 50% gets thrown away in the operating room. I want
100%.
to fit it the size of the wound because I'm trying to maximize our healthcare economic dollar and get the best outcomes I can. So this is where when you're looking at 1, 2, 3, 4, 5, 6 plus pieces, various sizes, I can measure and match, and that way I'm getting the best utility. So again, I think this shows great leadership and forward thought, knowing that there's a whole host of different sizes of ranges of wounds that we're going to deal with. This gives us the allowance to match up and get that opportunity. And then of course there's the non-fenestrated and the fenestrated, right? So again, I'm showing the fenestrated here, but it's a good match to be able to look at our wounds and get that best value prop.
Yeah. Well, being shelf ready is like in and of itself a game changer, right? And then having multiple sizes, so you're really filling the gap of the right patient, the right size, the right product, like all of the things that we worry about from a safety and risk perspective, we're addressing with this. And I think it's phenomenal. I love the technology. I think it's very innovative. And, I'm looking forward to more and more literature about this product.
Yeah.
And I think the other opportunity is just because it changes pH, it's a great opportunity to educate on why wound pH is such a critical component.
Oh, for sure.
Right. And to expand on that, most of the wounds that come into a clinic are chronic inflamed wounds. So having something that can change the wound bed environment it's what I'm after. So Mark, I really appreciate you highlighting this product. You can contact Renovaderm. They have all the posters and scientific data on their website. So you should see that on the bottom of the screen. And Liz, I want you to now take time and tell us what's going on with the APWCA that's coming up in June.
Yeah, so June 23rd, we're going to have our anniversary party. And then we're also going to be giving you more information about the Save the Date for Wound Week 2022 in Philadelphia, an in-live person conference. Everybody's very excited for that. It's going to be February 23rd through the 26th. But be sure to check your emails and go to www.apwca.org to join our organization that is for clinicians and by clinicians.
And Liz, do you have to be a member to attend a celebration coming up on June 23rd?
No, absolutely not. And it is free for all. So please come and join. We have lots of opportunities. You're going to be able to win a few items. And also, if you join the APWCA and you mentioned the Frank and Lizzie show, you get entered to win a $25 gift certificate from the APWCA. So please subscribe to us, and share our content. Our goal is to educate you and other wound care clinicians.